Dear students, dear colleagues, we continue the psychiatric lectures from University of Page, Department of Psychiatry and Psychotherapy, and this is the 5th year, this is the 3rd semester. And today's topic are factitious disorders and impulse control disorders. Factitious disorder was previously called as Munchausen syndrome. Maybe you are more familiar with this term, which means by definition that the patient consciously produces a physical or psychological symptom or complaint, lies a complaint or produces a physical sign, a physical symptom. And the reason of this is that the patient would like to put himself, herself into the sick role. The patient wants to get cured, the patient wants to get diagnosed, the patient wants to be in the sick role, and this is the reason behind this conscious and voluntary symptom production. And this is not malingering, because in malingering the patient has a conscious goal. For example, the patient don't want to go to the army, or the patient don't want to go to have an exam because he do not have enough knowledge for it. And this is malingering, when there is a known specific goal from the side of the patient. In factitious disorder, there is a conscious symptom production, but there is an unconscious wish to have the sick role. And impulse control disorders we shall see later. So this is a slide which makes a differentiation between somatoform disorders, factitious disorders, and malingering. In somatoform disorders, which is also called somatic symptom disorder, we had seen previously that there is an unintentional symptom production. Think about conversive disorder, or previously called hysteria, when the patient develops a paralysis, and the goal of the symptom production is unconscious. The patient has an inner intrapsychic conflict which leads to an unintentional, not voluntary symptom production. The patient develops paralysis, or the patient develops conversive blindness, which doesn't mean that the patient is not blind, but the patient really doesn't see in conversive blindness due to a psychological conflict. So this is somatoform disorder. The second, which I already summarized, is factitious disorder, when the symptom production is intentional, is voluntary. The patient produces a symptom, for example, takes a coumarin and produces hematuria, and the patient puts himself, herself into the hematuria patient position and waits for the diagnosis and so on. So, but he really knows what he had done. But the goal of the symptom production is unconscious motivation for the sick role. So what the patient doesn't really know, that he has an inner unconscious desire to be in the sick role. And in malingering, the symptom production is intentional, but in contrast to factitious disorder, the goal of the symptom production is a conscious personal gain, to get money, to get time of work, to not to go to army, and so on. So these are the three which very much should be differentiated: somatoform disorders, factitious disorders, and malingering. Factitious disorder, Munchausen syndrome, can appear with physical symptoms, can appear with psychological symptoms, and can appear physical and psychological symptoms when the two are coexisting. In physical symptoms, for example, the patient can learn the symptomatology of appendicitis, and the patient during the examination, abdominal examination, imitates the symptomatology of this illness, which can lead to, for example, to an appendectomy, because the surgeon is not sure whether it is a true appendicitis or not, and the operation is done. And this kind of activity can be typical. Or the patient uses a drug which causes some symptom, and which can lead to a physical symptomatology, and the patient has an unconscious wish to be in the sick role. This is also can happen. Or with psychological symptoms, it can happen that the patient, for example, says to the physician that he is hallucinating, which is not true. Or the patient speaks about suicidal ideation, which is not true. The reason for this lying, we can say, is that the patient wants to get a psychiatric care, a psychiatric treatment. So this is, and the two can be combined, the two can be coexist, the physical and psychological symptoms. I have two very short case vignettes which to mention very shortly. The first is the hematuria patient, the other is the PTSD or suicidal crisis patient. In the hematuria patient, there was a nurse who used coumarins and produced hematuria, and the patient was admitted to a urology department, and the diagnostic procedure was introduced to find out what is the reason of this hematuria, and after a few days, nothing was found, no tumor, no other cause, one of the nurses at the ward discovered coumarins in the patient's bag, and the patient, nobody knew that the patient used coumarin, and there was no reason for the patient to use coumarin, there was no illness which would explain this. So it became clear that the patient voluntarily, intentionally produced the symptomatology. And when the doctors tried to face the patient with this fact and ask the patient what is the reason that she produced the hematuria, they couldn't find the patient. The patient disappeared. And typically this patient, after a few weeks or after a few months, appears in another hospital, in another city, typically during the Saturday evening, and will get an admission again with the same or with a similar symptom. So this is the hematuria story. We have another story, the PTSD or suicidal crisis story, when after a tragic train bus accident which happened in Hungary in the 1980s, where many children died because a train crashed with a bus, school bus, and many children died in this tragic story. After a few weeks, at the psychiatry department, a patient appeared, a person appeared, a middle-aged male patient appeared and said that he was the train driver, and he started to speak about and spoke about suicidal ideation, spoke about PTSD symptomatology. He said that he had flashbacks, he's seeing the bloodied children after the crash, and he is seriously traumatized, said the patient, by this event when he was the train driver. And the patient was hospitalized with a diagnosis of PTSD and suicidal crisis. And after a few days it became clear that he was not a train driver, he never had been in this train bus accident, and he lied this. So this was a factitious disorder with psychological symptoms. He imitated intentionally the suicidal crisis with PTSD symptomatology, and this was a factitious disorder or Munchausen syndrome by psychological symptoms. Escher in 1951 described this symptomatology of factitious disorder, and there are some warning signs. As physicians, you should be aware. For example, borderline or antisocial personality traits are much common in these individuals. Childhood deprivation, childhood neglect is important, and the reason that these individuals want to get continuous care, continuous observation by the physicians is that they suffered a serious neglect or deprivation during their childhood. There are frequent self-harm, so there is a masochistic tendency, we can say, self-harm tendency in these individuals. Abdominal scars are many times can be found, and many hospitalizations. The typical is the hospitalization during the weekend and during the evening when young doctors are in duty, so the well-educated patients and the less educated young doctor meet each other, and this can help the patient to put himself, herself into the sick room. And there is a special form of factitious disorder Münchhausen by proxy, factitious disorder by proxy, or it is recently called factitious disorder imposed on another, when the mother introduces or does symptoms in the case of the child, and they go to the pediatrician, and the mother doesn't tell that she was who had produced the symptom, and the child is hospitalized together with the mother. So the mother gets the role of the caring mother and who get cared by the pediatrician. So this is a special form, and this can be very dangerous to children because mothers can sometimes seriously harm their children because of this inner wish to get attention by medical professionals. You can see here the DSM-5 diagnostic criteria for factitious disorder imposed on self. It's a falsification of physical or psychological signs or symptoms or induction of injury or disease associated with identified deception. The individual presents himself or herself to others as ill, impaired, or injured. The deceptive behavior is evident even in the absence of obvious external rewards. The behavior is not but explained by other mental disorders such as delusional disorder or other psychotic disorder, and there is a specification that can be a single episode or it can be recurrent. And also you can see the factitious disorder by proxy, which is recently called factitious disorder imposed on another, where the falsification of physical or psychological signs or symptoms of induction of injury or disease in other association with identified deception. The individual presents another individual, a victim, we can say a victim, to others as ill, impaired, or injured, and the same categories, the same diagnostic issue can be found in this form as in the previous one. It also can be a single episode, or it also can be recurrent one. And now, after the factitious disorder or Münchhausen syndrome, we turn our attention towards impulse control disorders, which are characterized by increasing arousal before the abnormal habit is occurring, and relief during and or after the action. So there is an inner tension developing much more and more, inner arousal, and the patient does something and this arousal goes down. Let's see the most important diseases here. The first is intermittent explosive reaction when the patient has a serious impulsive act. The patient attacks somebody after very small triggers. So there is a discrepancy between the trigger, between the stressor and the mobilized aggressive behavior. For example, somebody asks a cigarette from another person and the person attacks the guy, that why he's not doing this, and seriously harming the person who asked for a cigarette, which there you can see that there is a discrepancy between the trigger and the mobilized behavior. So this is intermittent explosive disorder, which has a forensic importance because if this can be diagnosed, it makes a decrease in the punishment, it leads to a decrease in the punishment because this is an illness. Pyromania, which means that the patient has an inner wish, developing desire to burn, to make a fire. For example, there was a famous patient in the 1970s in Hungary who burned the Hotel Intercontinental, and from the Buddha side he saw the burning hotel, and he masturbated during, and this was a famous case of pyromania, and this also has a forensic importance because it's an illness. Kleptomania, when the patient has an arousal to steal. The patient has money, the patient doesn't need the object he will steal, but there is an inner wish to steal. Here, differential diagnosis is important because antisocial motivation should be excluded because most of the individuals steal because they don't want to pay or they can't pay, and this is not kleptomania, or in some other cases mania or dementia can be the cause of stealing. So kleptomania should be carefully diagnosed. Hypersexuality or sex addiction can be mentioned as one of the impulse controls, where the patient has a continuous wish to have sex or to view pornography or to develop new and new partner relationships. And this has a compulsive nature. Pathological buying or oniomania, which is also an interesting disorder, that the patient has 50 pairs of shoes and she, typically she, buys a new one. So this is pathological buying. Excessive internet use or internet addiction, a recently introduced term which we know, or smartphone addiction, which is typically appearing during the adolescent period, and many adolescents show the symptomatology of smartphone addiction. They can't live without their smartphone, they can't be without the smartphone, using a smartphone continuously. And excessive solarium use, which is also recently described impulse control disorder. The etiology of impulse control disorders is also interesting. There are some psychological factors, as trauma, for example. Suffered trauma can lead to these problems of regulating impulses. Object loss, loss of a significant other, loss of a significant important relative. This is, for example, what we see in the cases of kleptomania or pathological buying patients, that they lost a relative, and unconsciously, in a symbolic way, they try to compensate the lost object, the lost person, and they steal or buy objects instead of. And they don't know consciously this relationship between the non-worked-through object loss and the pathological behavior. And disturbance of aggression control is also can be at the background, and some neurobiological factors also important to be mentioned. Disturbance of serotonergic transmission, and we shall see that antidepressants which have an effect on serotonergic transmission had a good effect on impulse control disorders. And ventromedial prefrontal cortex involvement was proved by brain imaging studies as a neurobiological background of these problems. As a differential diagnosis in the case of impulse control disorders, you have to exclude psychosis, mania, dementia, antisocial personality disorder, and intellectual disability or mental retardation. So these are the most important diagnostic criteria you should also think about if you see a patient with, for example, kleptomania or intermittent explosive reaction or other forms that you have to exclude as a differential diagnostic issue. The therapy or the treatment of impulse control disorders can be complex or should be complex. Pharmacotherapy as mood stabilizers, typically carbamazepine, valproate, maybe lithium, maybe lamotrigine should be introduced, or SSRI antidepressants, you know, the selective serotonin reactive inhibitor antidepressants, fluoxetine, fluvoxamine, paroxetine, sertraline, citalopram, and escitalopram. So these antidepressants can be used in these cases, and as psychotherapy, psychodynamic psychotherapy can be introduced when the unconscious intrapsychic conflict should be worked through, or behavior therapy as positive reinforcement or aversive conditioning can be a solution, a psychotherapeutic solution for these problems. Self-help groups is the last one. You know that the classical self-help group was AA, Alcoholics Anonymous, when alcoholics gathered without therapists and they, in a self-help way, introduced the treatment form from the 1940s. And new forms of self-help groups were introduced in impulse control disorders, as for example, Sex Addicts Anonymous, when patients with sex addiction together try to help each other. So this was a summary lecture on factitious disorder, which was previously called Münchhausen syndrome, and impulse control disorders. And I wanted to highlight the most important aspects of these phenomena. So thank you for your attention for today, and we will continue the education.